presentadores, que es el doctor George Gallo y el doctor Shimony, para que nos ayuden con los siguientes temas. El profesor Gallo es profesor de neurocirugía, pediatría y oncología de la Facultad de Medicina de la Universidad Johns Hopkins. Se unió al personal en septiembre del 2015 como director del Instituto de Ciencias de la Protección Cerebral y en All Children's Hospital. El tema que vamos a ver con los doctores es diagnóstico y manejo actual de tumores cerebrales en edad pediátrica. Así que, please, Dr. Shimony. Supongo que esa me la llevo, ¿verdad? Sí. Okay.
Hello, sir. Si quiere apuntar, lo puedo pasar. Si gusta, la puede poner la presentación. Sí. Déjame la ajusto. Thank you. Okay. Good morning, everyone. Sorry, I'm going to speak in English because if it's going to be in Spanish, it will not work. I'm very happy to be here, and I think our visit here was very good. You have a wonderful facility, and I'm personally hope you're going to have more like this in Mexico. So we're going to have a very brief review about pediatric brain tumors. We cannot cover the whole topic. This is a very wide one. Hence, I'm going to focus after a very few points about two of them that we actually met here when we operated in the last few days. So pediatric brain tumors are basically, unfortunately, one of the very common tumors that you can find in the pediatric population. This is the number one cause for death from cancer among kids. When you look at kids, this is the most common solid tumors in the population below the age of 15. Yet, when you look about the amount of funding and budget that is invested in pediatric brain tumor research and try to find any kind of a new solution, this is less than 4% from the actual budget. The FDA just recently approved that every drug that goes into the market in terms of chemotherapy need to be tested on kids from the age of 12 and above. But this is just recently, meaning the year of 2019. Before that, most of the drugs never been tested on kids, meaning the tools that we have to treat kids are much less than the one that we have for adults. Now, when you look at that, and we know that brain tumors will kill more than any other cancers for kids, and you look at this very awful statistics, you see that when you look at leukemia, which is very common, yet we have very good solutions, and most of the kids will survive. When you look at diffuse brainstem glioma, less than one of them going to survive eventually, and morbidity and mortality from these kind of tumors is very high. So we need to have a change, and change is coming actually. We're going to discuss about it very briefly today. When you look at the brain tumors in pediatric population, it's not just the way that it looks in the MRI, because there is a big difference between a kid that is 6 months old of age, or 5 years old of age, or 15 years old of age. And the tumors that we see are basically different from if it's infratentorial, supratentorial, and the age of the patient. We see different type of tumors when they are very little kids. Basically, unfortunately, the more aggressive one going to be when they are infants, and less as they grow into adulthood. And you can see meningioma back there around the age of 20 when they become adults, and we all know that meningiomas, although can cause a lot of harm, still are benign tumors in most of the cases. So location matters, and we know that different kind of tumors in pediatric population will come in different location. One of the most challenging issues with pediatric brain tumors is the fact that although a lot of them are going to be benign, the location is very problematic. So you can have a very relatively benign tumor for a kid, but its location is in the brainstem or in the thalamus or anywhere in between. The big change that we had in the WHO in 2016, talking about midline gliomas, basically came from kids because they have so many of these. So the challenge is very high in terms of surgical skills and in terms of treatment afterwards. So when we take the brain as a model and we look at the different tumors, I hope you can see it, yes. So the polycystic astrocytoma, which is very common, usually we're going to find them anywhere around the posterior fossa or around the optic pathway gliomas, the brainstem gliomas, which now has a transition from the regular DIPG to something that is more midline gliomas, harboring more thalamic tumors as well. And we have the medulloblastoma that usually we're going to find them in posterior fossa, and the ependymoma that we saw one of the cases here, and more. Now, as I said, this is the time for a change. And what we see in the last few years, there is basically explosion of research in pediatric. There's a lot of articles coming out. There is a lot of research in terms of genomic. There are facilities that now basically do a full exosome genetic evaluation for kids to try and see if we can learn something new. Unfortunately, a lot of this information is still let's learn about it rather than let's have a new treatment, but that's a start. I'm going to jump into two cases that are going to be parallel to the one that we saw here. So let's jump in. We have a 4-year-old girl, one of the patient that we operated back in Hopkins. She knows to have a fourth ventricle tumor. She has a mild hemiparesis, but no other major deficit. We look at the tumor, it's in the posterior fossa, maybe involving the brainstem, maybe has some cyst, and we think, okay, maybe that's a polycystic or ependymoma, and we go for it for a resection. Very bad location, maybe we're not going to be able to take it all out. Pathology came back as anaplastic ependymoma, but the pathologists use another term, group A, which is relatively very new. What does it mean? Now, we look at the images after surgery, and there is a small remnant. What are we going to do with it? What are you going to suggest to your patient? It's a kid, it's a 4-year-old. This is not a 40 years old. Are we going to use radiotherapy? Are we going to use chemotherapy? Maybe a combination of the two. Or maybe it's better to go back to the OR and try to resect more. It's a different kind of decision making when you taking care of a 4-year-old rather than a 50 years old. Now, back in the days, the treatment chart for ependymoma was relatively, I would say, simple. You try to do your best in the OR. Most of them, if you resect them all, that's A-okay, and that's it. But if it has any kind of anaplastic features, then you need maybe to involve radiation sometimes, or chemotherapy, etc., etc. Those are old news. We still follow this mechanism of treatment, but those are old news, because now it looks like this. And this is an article for 2015. I just came back from a conference about pediatric neuro-oncology, and there is more. And this is just for ependymoma. Now we know that this family of ependymoma, that once we used to call them like one family, it's not actually a family. They are separated. Supratentorial ependymomas are completely different from infratentorial ependymomas, which similar to spinal cord, but still different. Which means that we might need to give different treatment, and there is different response for radiation therapy. We're not going to go for all of these very tiny rows about the molecular subtypes, but that's just to give an example. Now, when you jump in and you look at that, we still aim for gross total resection. Now, in oncology, neuro-oncology, whenever we say, hey, we aim for gross total resection, it means that for now, this is the best tool that we can offer, meaning the other tools that we have are not as good as we want them to be, meaning the chemotherapy will not give you the same the same answer. The radiotherapy will not give you the same answer, or maybe you want to prevent radiotherapy because that's a kid. So when you look at that, we aim for gross total resection, and a study that came from St. Jude in the recent years showed that especially for kids, if there is a remnant, go back and resect that again, if you can do it safely. And they actually showed that they went back 3 times for the same patient in the period of time of 2 to 3 months to resect the tumor again, and that's the way they achieve a better solution for the patient rather than to go for chemotherapy or radiation therapy. And the reason is that there are subtypes of ependymoma that nothing really helps them. Now, gross total resection is still the very best tool for spinal cord ependymomas, and working with Dr. Jallo sitting here in the audience, he was one of the pioneers in the realm of spinal cord tumors, and we did quite a lot of them. If we can resect all the tumor out or most of it out, that's the best solution for the patient. Now back to our patient. This little girl, we saw that she has a group A. What does it mean? It's still not in the classification of the WHO, but it's coming in. Group A, unfortunately, we see more in kids. Remember what I told you. The younger they are, usually the tumors are worse, unfortunately. So we see that more in kids, and it almost has no response to radiation therapy. Meaning almost the only tool that we have in order to give them any kind of cure is to go and have more resection. So we need to do our best to get gross total resection. It was shown that whenever we have a subtotal resection, they do worse. On the other hand, when they get into adolescence and maybe adults, ependymoma tend to be much easier and much nicer. Those are group B. This group actually respond very well for radiation therapy. So if you have a remnant and you cannot go back and resect it safely, radiation will do the job. So we see that understanding the subtype and the very fine details of molecular biology does make a difference. It means that for our patient that has a remnant to go back to the family and say, hey, let's try radiation therapy, that's a big no-no. That won't help her. If you can go back and resect that, do it. It's better for her than to try radiation, because every treatment we choose, there is a meaning for it. The supratentorial ependymomas are completely different, and now we basically make our diagnosis less on depending on histology and more on molecular biology. And we know that the RELA fusion, this is one of the fusion that we found at supratentorial ependymomas, is basically a criteria in order to make the diagnosis. This came into the classification of the WHO already. The group A, group B for the infratentorial will do it in the next round of the criteria. For this type of tumors, which usually tends to have a better prognosis, the best treatment will be gross total resection. And the use of radiation, it's still controversial, and most of the centers will say that if it has in histology anaplastic features, yes, push for radiation therapy. If it's not, maybe just follow the patient or go back and resect. So what do you do if it's not clear? You try and find clinical trials. For every patient that the treatment is not clear-cut, if we can enroll them in clinical trials, it's better for the patient and it's better for the future. And there's quite many of them. I'll try to push for another case. So we had another case that we did here. This time it was a pilocytic astrocytoma. Pilocytic astrocytoma basically in a way like a benign tumors. What they know to do, the cells, is basically secrete fluid and create big cysts. The problem is the location. Most of these tumors will find a way into the posterior fossa, creating a very large cyst, and the result will be most likely an obstructive hydrocephalus. Now, this kid is a 14-year-old. He came from a different country that had 2 surgeries in the past for resection of pilocytic astrocytoma. They left a remnant. If I recall, he even got chemotherapy for that with no success. And he came back because now he has, again, a very big cyst, and we see the remnant. It's very clear. It's there. What do you do? Do you say, okay, what are your symptoms? Your symptom is hydrocephalus. Let's put a shunt in. and forget about it. Or he's 16 years old. The tumor showed that it can grow because it keep on growing. Maybe we need to give him a better treatment. So chemotherapy, not really working. Radiotherapy, maybe, 16 years old. Or try to go back and take it out in surgery. So again, like the chart that we saw for ependymomas, in the past, that's what we did. And this is already old news because we defined that by pilocytic astrocytoma, WJ1, mainly surgery, and then as you grow up towards glioblastoma, you add up adjuvant treatment, chemotherapy, radiation, and maybe the combination. Not anymore, not like this. Because now, this is low-grade gliomas for kids. Low-grade gliomas for kids now is completely different. Again, like we saw in ependymoma, the molecular subtypes get into action and we start to define them by that. We know, for example, one of the very hot topic is the tumor has this thing that called a BRAF mutation. What does it mean? We found that through the cell cycle, there is a mechanism that involves some protein and cytokines that you can use in order to attack this cycle and maybe prevent this tumor to grow. Some of the centers start to think about it. Okay, if they have the mutation, maybe we can use it as a second step after a subtotal resection, shrink the tumor, go back and take the whole thing out when it's small. Remember, the problem with pediatric tumors is mostly not the size, it's the location. Most of them are very problematic locations. Now, the BRAF family, we have the mutation that is what we use now. There are more, but this is the most common one, is the V600E. This is a targeting agent, potential targeting agent location. And the two drugs that are now being used in some of the trials, still under trial, are the vemurafenib and the dabrafenib. Both of them showed very nice results, especially with ganglioglioma, less with pilocytic, but it's very worthwhile to test that, because if your patient has it, it's worthwhile to do it. And I'll put in an example that I'm facing now with. I have a patient that is 16 years old. He had a resection on ganglioglioma going and engulfing the brainstem. He has a remnant after the surgery that was 2 years ago. Now the remnant is growing. We went back, we asked pathology, hey, please have a look again if he has a BRAF mutation, and he has a BRAF mutation. So now he has another option for treatment rather than just surgery. Maybe he will respond for those antagonists, it will shrink up his tumor, and I can go back and take the tumor in a more safely manner. Now, these are not the only family. There is another family that some of you may know from the tuberous sclerosis pathology with the subependymal giant cell astrocytoma, the SIGA, that we know that mTOR inhibitors like everolimus can give us very nice result. We lately found that everolimus can be used for high-grade gliomas in kids and give a very nice result as well. But as you see from the way that I'm saying and talking, a lot of that is still under trial. And that was for low grade only. When we look in high grade in kids, high grade gliomas, although can have the same name as in adults like glioblastoma, completely different tumors. The reason is, as you grow older and become 30, 40, 50 years old, you have more mutation. You have methylation, MGMT, so you have more actual options for treatment. The pediatric tumors has less mutation. The actual thing that went into action in the last classification is the histon mutation. Those are the midline gliomas. Remember that we say that for kids, unfortunately, a lot of their tumors going to be in the midline of the brain, the very far-reach areas of the brain. This histon mutation, their definition is basically the lack of methylation. It means that the number one drug that we use for adults, the Timodar, that we use for glioblastoma, does nothing for kids, or at least nothing as a single treatment method. So, unfortunately, kids with high-grade glioma, the prognosis is very bad still. Maybe a little bit better than adult, but still relatively bad. There are plenty of new trials regarding the subtypes and optional molecular biology, maybe potential treatments, but still, we are still giving the same chemotherapy we did and we gave 10 years ago, meaning we have no breakthrough. But that's the way to do it. You have to enroll patients into trials in order to find something new. The one thing that we know for now, that unfortunately those BRAF inhibitors we just discussed about, doing almost nothing for high-grade glioma, because this mutation, we found it in less than 10% of the cases. The Timodal, the temozolomide we just discussed, as a sole treatment, does nothing. And there is one drug that maybe some of you heard about in the very bottom of the list, the panobinostat, that in year of 2018, people talk about it, oh, this is the new Timodal for kids. Now seems to be less attractive than before. So, as we said about the ependymomas, we need to enroll kids in trials. We need to send as much information as we can to big database in order to find new cure. So, I think I'm going to end up here and say that the realm of pediatric neuro-oncology is very interesting. This is a very interesting time to be dealing and try to fight pediatric patient with brain tumor. There's a lot of research, a lot of new things. As we speak, this presentation that was basically built now, in about a few months, going to be a little bit less relevant because things are changing and the change is ongoing. So hopefully we're going to have a new beginning and new solution in the near future, but for now we need to keep on fighting. Thank you very much.